Welcome, everyone, to the New Retina Radio Journal Club with the Vit Buckle Society, VBS. I'm your moderator, Yoshi Yonekawa from Wills Eye Hospital in Philadelphia. So today I'm joined by some big shot retina specialists from the Vit Buckle Society and going in reverse alphabetical order because I'm always at the end of the alphabet. So I'm trying to start a new trend here. First, Dr. Paula Pecen from Carolina Eye Associates, Greensboro, North Carolina. Welcome to the podcast, Paula.
Hello.
All right. Second, we have Dr. Anton Orlin from Weill Cornell Medical College in New York City, where I was a med student. Welcome, Anton.
Thanks for having me.
And lastly, Dr. Ajay Kuriyan, one of my awesome partners at Wills Eye Hospital and Mid-Atlantic Retina in Philadelphia. Welcome, Ajay.
Thanks for having me, Yoshi.
Okay, so just a few notes on our mission today. We're going to briefly summarize an important new article in our field and to have a discussion with our esteemed panelists. And today we're going to discuss DRCR.net's Protocol W. So the official title of the paper is Effect of Anti-VEGF versus Sham for Prevention of Vision-Threatening Complications of Diabetic Retinopathy, the Protocol W randomized clinical trial. The lead author is Raj Maturi on behalf of the DRCR Retina Network. And this paper was published March of this year in 2021 in JAMA Ophthalmology. So just a quick comment, but I don't know how you all keep track of all the DRCR alphabet soup, but I personally like to think of associations like Protocol V recently that was looking at eyes with very good vision. So I remember V for very good. And Protocol AB, that was another recent one. So, this study group is on a roll, and where they looked at anti-VEGF versus early vitrectomy for vitreous hemorrhage. So for that protocol AB, I think of A for anti-VEGF and B for like an Asian pronunciation for vitrectomy. And I'm not sure what I'm going to do for Protocol W though, so help me out with this. Okay, so first let's kick it over to Paula to summarize the premise and the methodology of this paper.
So, looking at the background or the premise of the Panorama study that Protocol W was written in, the Panorama study looked at aflibercept or 2 milligrams of Eylea injections given either every month for 5 months and then every 2 months thereafter, or versus every month for 3 months, then every 4 months thereafter, compared to sham injections in patients with moderate to severe NPDR, and looked at the rates of development of severe vision-threatening outcomes at 2 years, and found that basically either 19 or 16% developed vision-threatening outcomes in this patient group versus 50% with sham injections. So there was a decrease in vision-threatening outcomes in patients with severe NPDR at 2 years. However, there is no significant change in vision loss in these patients, or there's no significant change in visual acuity in these patients at 2 years. Thus, Protocol W was written to help try to find out longer-term visual change outcomes at 2 and then 4 years, as well as changes in outcomes and decreased visual acuity threatening complications like center-involving DME or PDR. And thus, patients with moderately severe or severe NPDR were recruited to the study with good visual acuity, with better than 20/25 visual acuity, type 1 or type 2 diabetes, and over the age of 18, who don't have any history of NV on a fluoresceint angiogram, a history of PRP, and no recent injections given for DME or diabetic retinopathy in the past 1 year. Patients were randomly assigned 1-to-1 to injections either with sham injections or 2 milligram aflibercept injections given at all visit time points from 0, 1, 2, and 4 months, and then every 4 months thereafter for up to 2 years, and then continued from the 2 to 4 year time mark. However, injections were then held if the level of diabetic retinopathy was mild NPDR or better. And ultimately, 328 participants were randomized with 399 eyes. And of course, rescue injections were also given if patients developed center-involving DME that led to 10-letter vision loss at 1 visit, or 5 to 9-letter vision loss that were reported at 2 consecutive visits, or if high-risk PDR developed.
Awesome. Thank you for that nice description of the methods, Paula. So Anton, what were the main results of this study?
So this was another excellent study from the DRCR network. Regarding their primary outcome, they did find that aflibercept works, so it prevents these potential diabetic vision-threatening complications, DME and PDR. So the 2-year probability of developing either center involving DME with vision loss or PDR was decreased in the aflibercept group, so 16.3% versus 43.5% with sham injections favoring aflibercept. Breaking it down further, aflibercept worked at preventing either one of these complications. So the probability of developing PDR was decreased in the aflibercept group from 13% to 33% in the sham group, more than a 2-fold reduction. And it also prevented center involving DME with vision loss, which was 4% about in the aflibercept group versus 14.8% in the sham group, which is more than a 3-fold reduction. But despite these decreases in these complications, the prevention injections didn't really translate into an improved vision benefit in this aflibercept group, specifically at the 2-year endpoint when comparing to the sham group who were offered treatment with rescue therapy once a patient developed one of these complications. So the mean change from baseline was similar between both groups at 2 years. The aflibercept group lost 0.9 letters compared to losing 2 letters with the sham group, and many of the other vision outcomes as well were similar in terms of final visions or letters gained or lost. And as was mentioned, we're still waiting on the 4-year data to see what the results are in more of a long-term follow-up.
Got it. Thanks, Anton, for that nice summary of the results. So before we take a quick break, Ajay, can you tell us about your initial quick reactions to the paper?
Thanks, Yoshi. First of all, that was awesome summaries by Paula and Anton. Always helps to frame these papers with these interesting protocols. But for looking at this paper, my first reaction is that we see that there's a similar vision outcome for these patients. So even though we can definitely reduce the diabetic retinopathy score, decrease the center involving edema, and progression to PDR, we're still not seeing a difference in the final outcomes when you compare it to the arm that's getting rescue treatment. And so it really underscores to me the importance of follow-up for these patients. And, I definitely recognize that these patients are being followed much more often and with a much greater degree of scrutiny than we might be able to in our clinics compared to like a reading center that's looking at these 7-field photos. But that being said, at this point, without being able to see a clear difference in visual acuity for these patients, I think the biggest take home for me is that I need to follow some of these patients a lot more closely than I would have otherwise. In terms of like changing my practice pattern and things like that, I think there is certainly a very small subset of folks that I think about actively encouraging them to try anti-VEGF at this stage for NPDR patients. But a lot of times I use it more as sort of like an explanation of options for the patients and hope that scaring them, talking about a needle in the eye will get them to really be much more adherent with their follow-ups and with their compliance for their sugar controls to try to continue to monitor them, hope that they don't progress.
Great points, Ajay. Thank you very much. We're going to be right back now after a quick break. And when we come back, let's talk about this paper more in detail and also how our panelists treat their own patients with severe NPDR in their own practices. Welcome back to the New Retina Radio Journal Club with VBS. I'm Yoshi Yonekawa here with Paula Pecen, Anton Orlin, and Ajay Kuriyan. So team, let's talk more about this paper, Protocol W. Let's start with Paula. What was your initial reaction after reading this really important paper? Was it good, bad, or ugly, and why?
I think a lot of the DRCR net protocols are very well thought out, and I do respect the DRCR net looking into this, especially since we see so many positive outcomes with anti-VEGF therapy in our patients with severe proliferative diabetic retinopathy, and we rely on it on these injections so heavily in general in our practices, in our medical and surgical retina practices. But I do have some misgivings about kind of weighing the risks and benefits of intravitreal injections in patients with good vision at baseline, sort of like patients in Protocol V with very good vision, especially patients had similar levels of visual acuity in this Protocol W. And, it's hard to reconcile doing injections to prophylactically prevent something that not every patient will develop. And even patients with the intravitreal anti-VEGF therapy in Protocol W, it wasn't a guarantee that all patients would prevent development of center involving DME or PDR, given that some patients, up to 16% still develop some of these complications.
Great points. Anton, what was your gut reaction here?
Like most of the studies that they put out, it's an important one. It's good to now have data and results for what kind of effect preventative aflibercept has in this specific patient cohort. With that being said, I have mixed feelings about the results and what kind of immediate impact it's going to have on clinical practice. On one end, it works in terms of preventing diabetic complications such as edema and PDR, which is obviously a good thing and important to show, but it just didn't translate into significant vision benefit in this cohort at 2 years when compared to rescue therapy once the problem arises. So again, interesting to see what the 4-year results are going to show and whether we do see a vision benefit. And as Ajay had mentioned, another very important comment is that the compliance and then completion rates in this study were extremely high, over 80% for the long-term visits. And this is important because we can provide rescue therapy earlier on when a problem such as PDR first arises. These patients still seem to do okay. So, of course, in clinical practice, we may not have such high compliance rates, and this study just emphasizes the importance of that.
Great. Let's kick it back to Ajay now. What do you think some of the limitations are of the study design for this paper? And what do we not know yet that you would want to know if you were designing a future study?
Thanks, Yoshi. So I think that they did a really good job of answering the questions that they wanted to answer. I think the methods were very well designed. In terms of the limitations, we certainly wonder whether the results from the aflibercept that they're looking at is applicable to other anti-VEGF agents. But in terms of what else we want to know and look at, I think we still don't have any good data about whether anti-VEGF provides any disease-modifying effects for these patients. And so it'll be really interesting to see if we can get our hands on the data for the OCTAs or FAs done in these patients to see if there's any decrease in non-perfusion progression. We know that there hasn't been any data showing reperfusion for these patients, but perhaps there can be some modification on the non-perfusion that's found in these patients. And the other thing is that we want to see what happens to these patients once they go off protocol. Does having this 4-year period of a very regimented treatment with anti-VEGF change their long-term outcomes compared to these patients who are on PRN? I think the 4-year data is going to be really huge, but then seeing what happens afterwards once they're off the protocol will also be really interesting.
Great points, Ajay. So let's move our conversation now to our clinic. And let's start with Paula. What's your personal current practice pattern when you have patients with a severe NPDR?
Yeah, so I think based on the results of Protocol W, I do bring up the fact that injections are a possibility to help decrease risks of complications and vision-threatening outcomes. However, somewhat similar to offering injections versus laser for PRP, like in Protocol S, every patient is different and every patient has somewhat different outlooks and levels of aggressiveness in terms of therapy. Some patients want every treatment available to try to save their vision or prevent loss of vision. And some patients are more laissez-faire, and some patients just need to be scared straight and say, okay, I'm going to get my blood sugars and my blood pressure under better control. I'm going to exercise, stop smoking. And so I will give them this information, but I'm not going to try to push patients into prophylactic anti-VEGF therapy unless a patient is wanting to undergo those risks of injections despite having good visual acuity at this time point. I am, though, anxiously awaiting the 4-year results and then potentially longer follow-up with results after stopping all anti-VEGF therapy to see if there are longer-term outcomes that may be sustained after anti-VEGF therapy.
Got it. So a pretty individualized treatment regimen that you recommend. Anton, what do you do in New York City?
Similar things. Of course, each patient is different. Typically with moderate to severe NPDR without edema or vision loss, I'll typically observe these patients closely and have them come back for follow-up every 4 to 5 months or so. With protocol W, I think it's really nice to have results to share with the patients. It's important to show the decrease in complication rates with preventative injection therapy, but it just didn't lead to improved visual outcomes at 2 years compared to the rescue therapy. And because of that, I'm not sure what kind of impact it's really going to have, whether I'm going to start treating more and more of these patients. Obviously, we still have to weigh the potential risks of injections and the potential treatment burden that patients may face. And at the very least, I do plan on incorporating at least the data from protocol W into my discussion with patients when going through this risk-benefit analysis to treatment. And, it's really going to depend on how motivated and compliant the patient is, whether we move forward with injections or not.
Got it. So Ajay, you started talking about this in the first half, but what do you do in your clinic? We're in the same practice, but we all have different approaches to things. And mainly, I want to know the reason why when I end up seeing one of your patients, they're totally in love with you and they won't stop raving about Dr. Kuriyan. What's your secret there?
It's mostly because I tell them how they could get an injection, but I'm choosing to observe them instead. And so, I agree completely with Anton and Paula, where at this point with the given data, for me, I'm definitely not actively encouraging it in most patients. There's a small subset where I see like very aggressive progression between like one visit to the next, where I think about it a little bit more. I've had one patient actually request it because his other eye is getting injections and he just openly admits that he's just not going to control the sugars. And so he knows what his good eye is going to go to based on what his other eye was. And so he just wants to get injections. All that being said, it's definitely few and far between for patients with just NPDR that I'm injecting. I think like a total of less than 3 patients that I'm actually doing this for. But I think that there's a huge benefit in talking about this and seeing these percentages that we can quote for the risk of progression. And I think that definitely has the possibility for improving some of the adherence to both follow-up as well as to the diabetic regimen. And, these injections are not without risk. 3 patients in this study developed endophthalmitis. And so that's a legitimate concern in these like very well-seeing patients.
Well said. Paula, do you think that do you predict that your practice patterns will evolve the next couple of months or a year or so based on these data?
I don't know if it'll evolve over the next couple of months or a year, but I think awaiting the results of the 4-year outcomes from this study will be a little bit more conclusive to see if there really are any differences in the level of visual acuity more longer term. I think that's maybe when I might make more changes or change my practice patterns. But right now, I'm mostly closely observing like Anton and Ajay.
Got it. And Anton, any final thoughts about this interesting topic?
No, just waiting for the 4-year results.
Got it. And Ajay, final thoughts?
Same here, and I'm really excited to see the FA or OCTA data for these patients.
Okay, we all want more data. So excellent. Thanks so much to Paula, Anton, Ajay for their sharing their expertise. And thanks to all the listeners for tuning into New Retina Radio Journal Club with Vit Buckle Society. And please stay tuned for more episodes where we break down the hottest papers in our field. And we have fun discussions like we did today. And everyone can download this podcast along with previous and future episodes. Follow New Retina Radio. Also, check out Vit Buckle Society on our website, vitbucklesociety.org. Apply for membership. And you can also catch the video version of this podcast on itube.net, which is, as everyone knows, a wonderful resource in our field. So please stay tuned for future episodes. Thanks, everybody.